Hi, I'm Cush, executive editor of RoomNow.com. It is Tuesday here at the ACR. We're hitting the home stretch, another busy morning, busy day. I want to tell you about a presentation I'm going to do later this afternoon. It's going to be a clinical symposia. It's called Autoinflammatory Syndromes from Bench to Bedside, or is it Bedside to Bench? We're going to discuss the science of autoinflammatory syndromes with Dan Kastner doing the first presentation, and then I'll be following that up with a sort of clinical approach and therapeutics, and basically showing what we do really from the bedside to the bench in managing these very difficult patients with febrile disorders. I'll cover some of the autoinflammatory disorders, including FMF and TRAPS and the cryopyrinopathies, the CAP syndromes, but I'm going to get into mainly Still's disease, something I have a long interest in. Still's disease, as you know, is a juvenile disorder that actually has an adult continuum, and when that happens we call it adult onset Still's disease. There are no criteria or diagnostic tests. There are some proposed guidelines for diagnosing this syndrome. I like to use the Cush criteria, which says that you need 2 points for every major criterion. The major criterion being high fever, spiking daily fevers greater than 39 degrees centigrade is number one. Number two, the evanescent rash, the JRA rash that comes and goes. Number three, simultaneous elevation of white count and sed rate. Number four, seronegativity. And number five, carpal ankylosis, seen in 50% of patients, but nonetheless fairly specific for Still's disease. For every one major you lack, you get 1 point for a minor. Age of onset less than 35. Prodromal sore throat. Involvement of the liver with LFT elevations, or what I call RES involvement, reticular endothelial system involvement. That's hepatomegaly, splenomegaly, or generalized lymphadenopathy. Next would be polyarthritis, and then following that would be the development of tarsal ankylosis. Also not common, but fairly unique to this condition. The overall approach to these patients with febrile disorders really hinges on the duration of fever. In the case of Still's disease and systemic onset JIA and maybe Schnitzler's syndrome, you get daily fever. It's not genetic and it can occur during adulthood. In the other disorders, it's dependent upon the duration of fever. So if you have 1 day of fever, you should think about FCAS, familial cold autoinflammatory fever. If you have 3 days of fever, you should be thinking about either Muckle-Wells syndrome or familial Mediterranean fever, or FMF. If you have 2 weeks or more of fever, you should be thinking about TRAPS syndrome. And so 2 weeks, most TRAPS syndromes, it's really like 2 to 3 weeks, and then they go into remission and it comes back. So it is the duration and then the interval. So the periodicity, the height of the fever, when the fever occurs, these are all very important in making the diagnosis. I'll give you 2 more pearls about Still's disease. Number one, Still's is a quotidian disorder. It is a truly circadian disorder. The fevers occur either late in the afternoon, but usually late at night, and they occur at exactly the same time every night. The patients will look at the clock and they'll say, it's going to come at 11 p.m. because at 10:58 they get shaking chills, and that goes on for 20 minutes, then their fever shoots up, lasts for 2 or 3 hours, and then fever comes down, they defervesce, they sweat, they change their clothes, they change the sheets, and they look pretty good when you see them at 7 a.m. So a Still's fever is almost never at 7 a.m. So it is that diurnal, truly circadian pattern that's very, very important. The second thing is, how do you follow these patients? The best biomarker that I've learned from my colleagues at Baylor and at Texas Scottish Rite Hospital is aldolase. Aldolase goes up significantly in patients with active inflammatory, often IL-1 responsive disease. The CPKs are normal, but these patients do have elevated LFTs, they do have a lot of myalgias and whatnot, but this is largely liver-derived, and it goes up very high, 12, 15, 35, and it'll stay up while they have active disease and come down once you've been effectively treating the patient, either with steroids, methotrexate, an IL-1 inhibitor, or an IL-6 inhibitor. Anyway, you want to know more, come to the session starting at 4:30 p.m. today. It's going to be in Hall 6C. We'll see you there. Tune into Room Now for more news and videos.